Hi everyone. So the best place where we learn medicine is in the OPD. So I'm going to transport you all to the medicine OPD now. So here is our first patient, a 65-year-old woman who presents to the medicine OPD with history of severe right-sided headache since the last 3 weeks. She describes it as a throbbing type of headache which is not associated with any visual symptoms of vomiting. She has noticed a sharp shooting pain when she tries to comb her hair over the region. She also gives history of feeling feverish over the last few weeks and has lost over 6 kgs over the last 6 months. She denies any joint pains but feels that there is stiffness around her bilateral shoulders and hips, which is typically worse in the mornings. So what do you all think is the diagnosis? So after today's class, you will be able to diagnose this correctly. So the condition which we all are going to talk about today is giant cell arteritis. Before we move on to this topic, let us understand what exactly is vasculitis. So there is vasculitis is itis. Itis means inflammation and vascular. So vascular inflammation is nothing but vasculitis. So this vasculitis is typically divided into the large vessel vasculitis, the medium vessel vasculitis and the small vessel vasculitis. Now when I was studying this, I always had a difficulty in finding what exactly is a large vessel, what is a medium and what is a small vessel. So let us try to understand that. Large vessel refers to aorta and its direct branches. So that is large vessel. Medium vessel are the main visceral organ supplying vessels and their initial branches. Small vessels are the rest, that is the arterioles, the capillaries, the intraparenchymal arteries, the venules and some of the veins. So this is how we classify the large vessel, medium vessel and small vessel, what exactly they are. Now, the vasculitis has been classified by this important classification which is known as the Chapel-Hill classification. So by this Chapel-Hill classification, we can divide the various causes. For example, large vessel vasculitis, the examples for this are Takayasu arteritis and giant cell arteritis. Medium vessel vasculitis includes polyarteritis nodosa and Kawasaki disease. Small vessel vasculitis can be further divided into immune complex mediated and ANCA associated vasculitis. In the ANCA associated vasculitis, as we all know, we have the GPA, that is the granulomatosis with polyangiitis, previously known as Wegener's, and the eosinophilic granulomatosis with polyangiitis, previously known as Church-Strauss. In the immune complex mediated small vessel vasculitis, we have the IgA vasculitis, that is the Henoch-Schönlein vasculitis, hypocomplementemic urticarial vasculitis and cryoglobulinemic vasculitis. So this was the broad classification of vasculitis. Now coming to the giant cell arteritis. So as we all know, what we just discussed, it is a large vessel vasculitis. What are the other names by which it is known? It is also known as temporal arteritis or granulomatous arteritis. So it involves most commonly one or more of the branches of the carotid artery. Now what you should know, which is a golden point, is the most common vessel involved. Now the most common vessel involved is the superficial temporal artery. Now other branches of the carotid may be involved, but the most common vessel, which can be a potential question, is the superficial temporal artery. Next, coming to the epidemiology. Now always remember, it is in individuals aged more than 50 years. So if the age is mentioned as 20 or 30 in the question, think twice before marking GCA as the answer. The peak incidence occurs at around 70 to 79 years and it has a more female preponderance. The female is to male ratio is around 3:1. And an interesting point is it has a higher incidence in the Scandinavian nations. Alright. So the next things is the HLA association. Now NBA is always interested in HLE, in genetics and in numbers. So whenever you see these numbers, these points are highlighted and it is a good thing if you write them down separately and remember them. So it has a HLA-DR4 association and especially this HLA-DRB104 association. What are the other clinical features? Now, one of the most common associated syndrome is this syndrome called polymyalgia rheumatica, PMR. So, this is associated in as much as 40 to 50 patients of GCA. So, how do you know if a patient is presenting with this polymyalgia rheumatica? Again, they will present with an age more than 50 years. They will come with this typical pain and stiffness of the hip and pelvic girdle, which is bilateral. they'll say that they have this shoulder and hip pain, which is typically worse in the mornings and is associated with stiffness. This is the characteristic early morning stiffness, which is lasting 30 minutes or more. Then when you do your lab investigations, you will find that they have raised inflammatory markers. ESR and CRP will be elevated. And then when you want to do an ultrasound, a musculoskeletal ultrasound, what will you find? Typically in these patients, you find subdeltoid or subacromial bursitis or biceps tenosynovitis, all right? And one of the important features is this has a very good steroid response. Like if you start them on even a low dose of Vicodin, you will see a magical response. The patient will come back to you and say, wow, doctor, what have you done magic in just a week? So coming to the other clinical features, remember the most common feature is headache. An elderly female more than 50 years coming with a new onset headache, always think of giant cell arteritis. So now this is usually in the temple region, it can be temporal or occipital. So we discussed the most common symptom is headache. Now the most specific symptom is jaw claudication. So when they are chewing food, they can typically present with pain in the jaw, or sometimes they can even have tongue claudication. So these are the symptoms, which is the sign. One of the important signs to elicit is scalp tenderness. It's there in the word itself, scalp tenderness. So when you palpate as seen in the image, you will initially find a thickened nodular artery which is painful. Initially it is pulsatile, but with time and inflammation it can be non-pulsatile. So the most common symptom is headache, most specific symptom is jaw claudication, and important sign, scalp tenderness. So the other important feature is constitutional symptoms like fever, weight loss. So one thing you should always remember is any elderly patient presenting with PUO, always make sure you rule out GCA. Always check the scalp tenderness in an elderly patient presenting with PUO. This can clarify many a diagnosis. So now the next point. So what is the most dreaded complication of this condition? So the most dreaded complication is this visual complication known as anterior ischemic optic neuritis. So now this anterior ischemic optic neuritis typically presents with this altitudinal hemianopia. So if you see altitudinal hemianopia in one of the options, always think of this anterior ischemic optic neuritis. Next, now that we have understood the clinical features, let us try to understand the pathology. So in the pathology, I have made these 3 points. So these 3 points are typical of these conditions. Just 3 points, remember it. There is transmural involvement. What do we mean by transmural? Meaning all 3 layers of the artery are involved. Pan-arteritis. That the term is pan-arteritis. Second is it is non-necrotizing. Alright. And the third feature is presence of granulomatous inflammation. So it is known as granulomatous arteritis. So we have granulomatous inflammation. What do you mean by granulomatous inflammation? Presence of giant cells, epithelioid cells or macrophages. So 3 key terms: pan-arteritis, non-necrotizing, granulomatous inflammation. The other features in the pathology can include proliferation of the intima and this typical feature of fragmentation of the internal elastic lamina that you can very nicely see in the image which is shown. Take note of this image. This can also come as an image-based question. As a patient presenting, an elderly 70-year-old female presents with new onset unilateral headache since the last 2 weeks. Biopsy of the relevant structure is done and is shown below. What is the typical feature of this condition? So they will give transmural, non-necrotizing, granulomatous. Fourth option may be necrotizing. So that is the wrong answer. So always remember this image and the 3 important points. Next, how do we diagnose? So diagnosis is by lab investigations and the imaging. Lab investigations, first one is the inflammatory markers, ESR and CRP. These are inflammatory markers. This is an inflammatory condition, so it will be elevated. Next, always try to achieve a tissue diagnosis, which is the gold standard. So the temporal artery biopsy. So temporal artery biopsy should be at least 3 to 5 centimeter. Why should it be 3 to 5 centimeter? Because this condition can also have skip lesions, means there may be patchy involvement. Now, where else have we heard of this skip lesions? The answer is Crohn's. So just like in Crohn's, this condition also can have skip lesions, and therefore you need to have at least 3 to 5 centimeter of the biopsy. Now the second one important question is, can we do this temporal artery biopsy after giving steroids? Supposing you give steroids today, the patient will ask you, doctor, you have given me steroids, but will that not bring down the inflammation? The answer is, the temporal artery biopsy can show changes even after 14 days of steroids. This line is from Harrison's. So even up to 14 days you can do the biopsy. So guidelines say that you can also do the temporal artery Doppler. The temporal artery evaluation can be by the biopsy or the Doppler. And the next imaging is PET-CT. So any of these can be done, which will help in the diagnosis of this condition. So in this temporal artery Doppler, there is a very important image-based question, which is known as halo sign. Now what is happening is, as you can see in the image, the normal cross section of the temporal artery is what you are seeing, and this is normally compressible. In this temporal arteritis, what happens is, because of the inflammation, there is lack of compressibility in the temporal artery in these patients, and because of this we have a hypoechoic wall thickening. Now this hypoechoic wall thickening gives rise to the typical halo, which is there on top of the head of the angels, that halo. Halo sign is seen in giant cell arteritis. So these were the ways by which we can diagnose this condition. Now coming to the treatment. Remember, drug of choice is glucocorticoids, alright. So how much glucocorticoids do we give? Usually we give 40 to 60 milligrams per day for 1 month, followed by a gradual tapering. So one of the pearls which you should never forget is, when a patient with GCA is presenting with ocular signs and symptoms, pulse methylprednisolone, that is 500 to 1000 mg of methylprednisolone should be given daily for 3 days to protect the remaining vision. So this will be a typical your INICET question. So there will be a patient who is presenting with acute onset of vision loss. You have diagnosed GCA. How will you proceed? In the options, they will mention both prednisolone 40 to 60 mg and methylprednisolone. So because of vision loss, always you should choose methylprednisolone. Now one more important biologic which is used is tocilizumab. So tocilizumab, I am sure you all have heard before. It is an IL-6 inhibitor. It is an FDA approved drug, and the dose is good to know. It is 162 milligrams subcutaneous once every week or every 2 weeks. At our center, we are also using it IV, around 8 mg per kg. So one of the other steroid sparing drugs is methotrexate. So this is the treatment of this condition. So I am leaving you with this last slide where we identify key words to identify the diagnosis. So whenever these words are there in the question, because sometimes you will get a lengthy 8 or 9 line question. So you will have to quickly scan through and see if these words are there. If these words are there, always choose the option of GCA. Elderly, age more than 50, new onset headache, PMR symptoms, jaw claudication, scalp tenderness, raised ESR or CRP. When these words are there, immediately one bulb of GCA should blink in your head. So now I just want to convey this one point for those who want to go beyond the basics. So what I have spoken till now is cranial GCA, which is predominantly cranial symptoms. So apart from this, we also have extracranial GCA, that is also known as large vessel GCA. So it is a large vessel, so it will involve aorta and its branches. So most commonly the axillary artery can be involved, the subclavian artery can be involved. So GCA can be only cranial, cranial with large vessel GCA, or limited large vessel GCA. So now the latest guidelines are also saying, if you are evaluating for GCA and the temporal artery evaluation is negative, you can also do an axillary artery Doppler to confirm the diagnosis. So this is something for you to ponder over. So let's conclude the session with 2 questions. One is a PYQ which was asked in Neet 2022. 60-year-old female with new onset left-sided throbbing headache with pain while chewing food. On examination, following findings are seen. Which of the following is the first line for this patient? Now all our keywords are there here in this question. 60-year-old, new onset headache, throbbing headache, jaw claudication. So what is the first line? We read in our previous slide that the first drug of choice is steroids. Steroids is there in the options. So the option C is the correct answer. Next, which of the following is true regarding GCA? Biopsy should be performed before administration of steroids. Is it true? No, we just discussed that up to 14 days also we can do. Second option, ESR and CRP elevation are specific for the diagnosis of this condition. Is it true? No. ESR and CRP are inflammatory markers. If you have a viral fever today and check your ESR and CRP tomorrow, also it will be high. So it is not specific. It is usually high. It is sensitive but not specific. PMR has a prompt therapeutic response to low dose prednisone. Is this correct? Yes. I mentioned to you that low dose, the steroid response is characteristic. So that is the true statement. Let us see the last statement. Anterior circulation stroke can be associated with this condition. Now, what is important to note is, first of all, stroke itself is rare in GCA. When stroke occurs, the posterior circulation, that is the vertebrobasilar region, is the one which is most common. So anterior circulation stroke is usually not associated. This is a wrong option. So correct answer is option C. PMR has prompt therapeutic response to low dose prednisolone. Thank you all. Enjoy studying. Work hard. Thank you.